You're good.
All right, welcome everybody. This is the first lecture of an unknown number of lectures in our new series. Today we're just going to talk about some basics of X-ray reading and some fractures. Just knowing how to look at fractures, what to think when you're first looking at one, and why it's important to think about those specific things. Okay, so welcome everybody. Thank you for coming and listening to my talk. All right, so the first thing you want to do when you're looking at an X-ray is you want to get your bearings. You want to know what views you're looking at. You want to know what body part, and be sure to describe the side. And then you want to note whether they're skeletally mature or immature. That basically means you're looking for growth plates. Okay, when I was a medical student, I remember it was really hard for me to differentiate between a fracture and a growth plate early on. I would think that every growth plate was a fracture and think, oh my God, he has like 2 fractures, but you'll learn as you look at more and more X-rays. So those are the first kind of 3 things you want to open with. And then you want to get into your description of the fracture itself. So when you're given this, you'd want to say, this is an AP, oblique, and lateral view of the right hand in a skeletally mature individual showing a blank, blank, blank. You go into your fracture description. In this case, he doesn't have a fracture, so you don't have to do that part. But that's kind of your introduction. Kind of sets the scene for anybody who's listening to what you're having to say. If you're talking to someone over the phone, you can describe a fracture or an X-ray like that. Okay, and now we get into the fracture description. So there are 3 key things you want to look at. You want to look at the pattern of the fracture. You want to look at the location. So what part of the bone, whether it's proximal, midshaft, distal, that's important to know because there are different classification systems based on exactly where it is. The treatment methods will be different. Different things you have to worry about will apply to different parts of the bone. And then the deformity, that's the part that can confuse some people, but understanding how exactly the fracture is deformed will really help you with your reductions. They can help you with your molds when you make your splints, and they can help you surgically when you're actually treating them. Okay, so the fracture pattern, I'm sure a lot of you have already covered this in medical school. You have your complete fractures, which go all the way through. Bicortical, we talk about the cortex of the bone. You can see the cortex light up on an X-ray. It's like the really bright part on the outside. And when you're looking for a fracture, whenever I go to the radiology room, I like to learn from the radiology residents and see how they read fractures. And what they do is they'll trace the cortex all the way around and they'll look for a cortical break. That's kind of how they'll first recognize, hey, there's a little fracture here. So you look for the cortex, and then you can tell if it's complete or incomplete. The incomplete fractures tend to happen more in children because they have a little more plasticity to their bones. But I'm sure you've heard these terms before. You have your transverse, oblique, spiral, comminuted, and avulsion type fractures. Your incomplete fractures, you have your torus and your green stick. So just to review with pictures, the transverse fracture is pretty straight across, as opposed to your oblique fracture, which is kind of slanted. Your spiral is usually caused by a rotational force. You have comminution, which is when you have multiple fragments. And you have an avulsion fracture, which is typically from a ligament or tendon or attachment to the bone that kind of rips off that small distal chunk. And these are important to note because different forces act on these fracture patterns in different ways. So, let's ignore the fact that these are all femurs because this is like a convenient picture to show. All of these in a femur would probably be treated with an intramedullary nail most likely. But let's say this was in something else like an ulna. So with a fracture that's transverse, the way you want to kind of bring those pieces together is you can compress them directly together. This talk isn't really necessarily for going into specific fixation methods and how they work. I just want to kind of introduce these ideas to you. So with a transverse fracture, you can do something called a compression plate, where you have a screw here and a screw here and a plate that goes across. And this is, again, something I'll talk about in the next lecture probably, but you'll compress these 2 fragments directly together. Okay. Whereas if you have an oblique fracture and you try to do that, what's going to happen? You're going to have a little bit of sliding here. It's called shear. And you'll have the shear force where this fragment will go this way, this fragment will go that way. Okay, so if you don't account for that, you're going to get non-union or malunion of that fracture. Okay. With a spiral fracture, it's just helpful to know the mechanism. Likely, if you had a spiral fracture like this in the femur, an intramedullary nail would suffice. With comminuted fractures, you don't have to bring all the individual pieces back together, especially in a femur, like a big load-bearing joint. You can use an intramedullary nail that just spans the entire shaft. And the fragments themselves don't have to be brought together. It'll kind of just heal in a big callus. And you can actually bear weight on that rod as it's a load sharing device. And you can walk on that pretty much the next day, which is pretty cool. That's like one of the reasons I picked orthopedics, is because you can have people come in with these horrible femur fractures. They're just like bleeding into their proximal leg, and it's a horrible, horrible, painful condition. And they can walk out like a day or two later. So that was something that I really liked about ortho. And then you have your avulsion fractures, which are little fragments like this. You can kind of do something like a lag screw, where you can just put a screw right in here, compress this piece to that piece. And sometimes that's all you need to do. These are also important, like if you consider like a proximal humerus, right? So your humerus, like I said, the section of the humerus matters, right? You have your proximal humerus, you have your mid-shaft humerus, you have your distal humerus. The proximal humerus is its own like type of fracture because you have the attachment of all your rotator cuff muscles. All right, so the greater tuberosity of your humerus is a big bony protrusion where your supraspinatus, infraspinatus attach. And if you have an avulsion of that greater tuberosity, even though it's small, that can have some functional deficits in the long run if you don't fix it. Typically, I think it's like greater than 5 millimeters of displacement. You'd have to operate on that. Okay, so that's why these kind of fracture patterns are important to know, and not just because you're studying for step one. Okay, with an oblique fracture too, you can do something like a lag screw across this way, right, where you have the head of the screw here, and you have the grooves of the screw on this side, and as you drill it in, it'll compress this piece to this piece, with the head kind of serving as an anchor. And then to account for this shearing force, you can do something called a neutralization plate that kind of spans the side of the bone where the screw will go into, and that'll prevent the shearing from happening. Cool. Any questions, comments, concerns?
Jason, I don't know if you could see the chat, but there was a couple questions in the chat.
Oh, yeah.
Do you want me to read it off to you, or?
Oh, I got it. Yeah, thanks for just keep reminding me that they're there, because I might forget. But is there any risk of infection as well as host rejection with the screw going in an angle there? Yeah, so the last question, the screw would go in an angle. It would go in kind of like this. You want it to go perpendicular to the fracture line, ideally. So this one, is not super amenable to a lag screw because it is a little bit more transverse than you'd like it to be. If it were more oblique, that would be more amenable to a lag screw. I'm just using this as an example. Infection, there's always a risk of infection with any surgery, which is why, we make a big deal about surgical indications, right? You never want to operate unless it's absolutely necessary, because anytime you make an incision, you predispose somebody to the potential risk of infection. You don't really get host rejection and infection just with these screws. Anything metal you put into the body, actually, you guys learned from Sketchy, right? Like staph epidermidis likes that kind of, likes to make a little biofilm on like a metal surface. So, like I said, if you don't have to do it, you don't want to, you're always increasing the risk of infection. But typically just putting a screw in the body in and of itself, the infection rate isn't terribly high. Yeah, so the comminuted fracture, like I said, so this kind of going a little bit more into the next lecture I'm planning on giving. But with these comminuted fractures, you have basically when we can just dip into it really quickly for a little bit. You have absolute stability versus relative stability. Those are your two methods of fracture fixation. With absolute stability, you're really compressing the pieces together and making sure that they're like very form-fitting, making sure they're growing together. And in that situation, you won't get this callus formation. It'll grow right into each other. And that you want to do for more like your radius or your ulna, where the exact alignment is really important, because if you have a little bit of discrepancy there, you might lose 10 to 20 degrees of pronation, supination. That's important with your forearm. With your femur though, it has one purpose really, and it's just to load weight. So you don't really need to bring all those individual fragments together. You can just put a big rod through the shaft, and that'll just load all of your weight on it. And then these will kind of just heal. It's not going to look perfect, but it'll heal well enough for you to function every day without even realizing that you have those little fractures. You can also do something called a bridge plate, where you kind of have a screw here, and a plate that goes across, where it's just kind of serving to just keep things in place. And that's another form of relative stability as opposed to absolute stability. Again, I'm throwing a lot of terms at you, which I'll go into more in the next lecture. But you know, a comminuted fracture is more amenable to a relative stability fixation. Cool. I hope that wasn't too much at once. Okay, any other questions? Thoughts? Concerns? Okay, cool, let's move on. So here I'm getting a little advanced here, but I like the idea that, you know, these compressive forces, the forces we were just talking about, let me just go back for a second. All these forces, the shear forces, the compressive forces, right? Imagine if you bear weight on this, that'll compress down, that'll help you heal the fracture. Whereas if you leave it like this and you bear weight, you'll shear. And so those forces are important, and we actually use those to our advantage sometimes. So let's look at this example. All right, so hip fractures are basically an entire lecture of their own, which I plan on giving at some point in the future too, if possible. But you know, just to very basically go into them, your femoral neck fracture is a pretty common hip fracture. The femoral neck is, so this is your femoral head, this is your femoral neck, right? Here's your greater trochanter, here's your lesser trochanter. Your femoral neck is this part right here, the part that looks like a neck. Ta-da! So the reason why we treat these in elderly people, right? So in people over 65 years old, the mainstay of treatment for these is to replace the entire thing. You will either do a total hip arthroplasty, or where you replace the femoral head and the acetabulum, or you'll do a hemi-arthroplasty, which is half of an arthroplasty, where you only replace the femoral head component. Okay, and the reason why you have to replace the whole thing is because, one, this whole thing is in a joint capsule, it's intracapsular, so you don't get the greatest blood flow in there. And two, look at the blood flow of the femoral head. A lot of it comes from here, the profunda femoris, or deep femoral artery, okay? And then off that you have your medial femoral circumflex and your lateral femoral circumflex. And these are the primary blood supply to the femoral neck and to the head. Okay. The load-bearing portion of the femoral neck and head is mostly supplied by the medial femoral circumflex artery. And if you ever forget which one it is, I just say, is it this one or that one? It's this motherfucker right here. I'm sorry, I forgot this was recorded. Dr. Cott, if you're listening, I am deeply sorry, or profundally sorry. All right, I'll move on. I'm sorry, it's terrible. Okay, anyway, so we have here an oblique fracture of the femoral neck, right? So let's ignore the fact, let's say this is not in a 65-year-old. Let's say it's in a younger person, where you don't have to do a total joint replacement. An option there is you can do cannulated screws. You can take 3 screws or 2 screws and go straight up through the chute and they'll kind of go straight in here and just live there. Again, the problem with that is you have a high rate of non-union. That's a very common complication of these femoral neck fractures, where you treat them with cannulated screws. Okay, so if you think about why would there be a high non-union rate there? Well, it's because you have this oblique fracture where, imagine you're loading weight here, down here, and you're getting a shearing force, right? So you have your patient, you put your can screws in, they're coming back a few months later, the fracture isn't healing the way you want it to, you're noticing that there's a lot of shearing going on. So what you can do to resolve that is what's called a valgus wedge osteotomy. Osteotomy, osteobone, otomy to take out. Valgus is, the direction, lateral, and wedge is just the shape. It's a very creative name. We orthopods are very creative here. So you do your valgus wedge osteotomy, and you kind of bring this part down, and now your shear force has become a compressive force. And now, literally just walking around, you're facilitating your fracture healing rather than hurting it with a shear force. Shear, compression, shear, compression. Pretty cool, right? I thought it was pretty cool. So we're using these laws of physics and these fracture patterns to our benefit here, which is pretty sweet. Okay, so those were our complete fractures. Now we can go into our incomplete fractures. We'll just touch on this very briefly. Your green stick fracture, imagine you find like literally a green stick outside. Like, I know, like, orthopedics very creative, and you snap it and the distal part has a little chip in it, right? So there you go, green stick fracture. Taurus fracture is also known as a buccal fracture. It's where you have a bending force that causes this outward protrusion of the bone. And you can see it's like a little belt buckle. I don't know if that's like the original reason why it's called buckle. That's how I remember it. Okay, whatever you can do. All right, how are we doing? Any questions? We doing all right? I like to take things nice and slow. All right, cool. So now, like I talked about earlier, we have our location, right? We have proximal, distal, mid shaft. So this is really important because you have to take into account different considerations depending on where it is. So let's say you're the intern and someone comes in with this, right? You have your, this is called a tibial plateau fracture. But it's important to know that a proximal tibial fracture, otherwise, it's essentially what it is different from your femoral or tibial shaft fracture. This is a tib fib, but we're focusing mostly on the tibial shaft here. So there are a lot of important structures that come around here. Okay. I just got a question. If you have a green stick fracture close to a joint like in the ankle, you run the risk of permanent damage to connective tissues. Not really. If it's just a green stick fracture, usually, especially in children, like children heal like crazy. It's pretty remarkable. So if it's just a green stick fracture, typically you'll put them in a splint or a cast and they'll be a-okay. If you have, a severely displaced fracture, it's a different story. Patellar fractures, that's again, it's kind of its own classification of fracture. Your patella has, does anyone know like what the patella does? Like why were humans made with patellas? It's actually kind of fun.
Isn't it like a lever arm?
Yeah, exactly. It's like a
give you better, give you better like strength on the extension mechanism in the knee.
Yeah. Does anyone know like what that kind of bone is called? There's like a specific term for that. There's one in your hand too, right here. It's a sesamoid. So a sesamoid bone is kind of like something where there's like a bigger protrusion where like a tendon or something or a muscle will go over, so that you can have a higher torque force that gives you more force. So your patella can increase your knee extensor mechanism by a lot. And so that area is under a lot of tension. And so if you have a patellar fracture, a lot of those are treated with tension wires. which is a totally different, form of treatment that not really relevant to this talk, but just if you're curious. Cool. So, so going back here, so we have our tibial plateau fracture. So what kind of structures are we worried about here? Just shout out a few of them, like what, you're the intern, someone comes on in with that, like there are some things that you should be thinking about.
Are we talking about the tibial plateau or the femoral and fibular fracture?
We're talking about the tibial plateau fracture first. Yeah. Can you guys see my mouse? Is that?
Yeah.
Oh, yeah. So over here, like what there's a lot of structures over here that you'd be worried about. There's a lot of muscle attachments. Yep. You have your peroneal nerve that comes around the fibular head. You have your lateral collateral ligament. You have your meniscus in here. You have muscles that attach over here that come up from the thigh. And most importantly, what kind of comes in behind here? Comes behind your knee. Yeah. Yes. What is it called before it becomes your tibial artery?
Popliteal.
Yeah. So this is your popliteal fossa, and your popliteal artery here is dangerously close to this part of your tibia. Okay. So if you have a tibial plateau fracture, something we worry about is how is the blood supply to the rest of your leg? So if you have like a gnarly tibial plateau fracture, something we'll do is we'll make sure you have distal pulses, which you should always be doing with any fracture as part of your basic orthopedic physical exam. But a lot of people will get an ABI, which is an ankle brachial index, something that you'll read about in UWorld and first aid, but never think about until you're on your orthopedic rotation, where you take the blood pressure in your ankle and divide it over the blood pressure in your arm. And if it is greater than 0.9, you're fine. And if it's less than that, you got to worry a little bit. That means your blood supply to your lower extremity is being compromised, and you have to treat that very differently. Same with like a knee dislocation. You have to worry about that popliteal artery. You have to reduce that very quickly and just hope that your popliteal artery is intact. Okay, so you got to worry about all those things with this. Whereas with your tibial shaft fracture, there isn't like that much to worry about. I mean, you have some muscles that go across here. You have your tibialis anterior, tibialis posterior, and your extensors and flexor digitorum, but usually those are all okay. So this you can just put a rod right through, just like your femur. Typically, we don't even have to fix the fibula. And again, you can bear weight on that pretty soon after. So here's an example of how these are fixed, right? So like we said, this is your tibial IM nail, right? You open up the knee joint, you go through the proximal tibia, and you jam that rod down there, obviously with a little more finesse, you're not jamming it, and then you have your distal interlocking screws. These prevent rotational movement of your rod. There you go. Whereas here, again, we're talking about a different application of those shearing forces, right? So let's say you have a fracture line like this, okay? If you start bearing weight on it, this fragment is gonna start sliding down. So this is kind of your lag screw concept we were talking about, where you're screwing this piece into the rest of the tibia. But is that sufficient? Probably not, because you have this shearing force making this piece slide down. So you use what's called a buttress plate. This is a buttress plate where you're literally buttressing this fragment from sliding down, right? This little focal point here, it won't slide down because of this buttress. Pretty cool, right? I'm glad I'm the only one that thinks so. Anyway. Okay, so the next part is probably the most confusing part for people. We're going to talk about like the deformity of the fracture. So an important thing to note is that when you're describing the deformity, it's always in relation to the distal fragment. Okay, something that takes a little bit of getting used to, but if you just keep that in your mind all the time, it's a lot easier to keep it straight. So you have different ways to describe deformity. You have displacement. Okay, you have medial versus lateral, anterior versus posterior. And just, because we like to be special, we use different terminologies for like different parts of the body. So like in your arm, people like to use volar and dorsal instead of anterior posterior. In your leg, they like to use valgus varus as opposed to medial lateral, but they all mean the same thing. So you think about displacement, you think about length, right? You can have shortening or lengthening of the bone. You have angulation, like we were talking about. You have valgus varus, dorsal volar. You have rotation. You can have internally rotated or externally rotated. And again, these are all in relation to the distal fragment. Okay, so this is just a picture showing a bunch of examples. So again, this is an example of a femur on its side, right? So this is your femoral head. This is your femoral neck, your greater trochanter. So this is lateral. This is medial. This is proximal, and this is distal, just so you can get your bearings. So here we have what's called distraction, right? This isn't really displaced, really. It's not really angulated. It just kind of lengthened or distracted, okay? Here we have lateral displacement. Remember, again, this is lateral. This is medial, proximal, distal. So you have lateral displacement of the distal fragment. And, if you want extra points, you can describe the percentage of how displaced it is. So you could say this is, laterally displaced, like 25, 50%, right? And you see those cortexes, how they would line up. Here you have 100% displacement, and you have a little shortening here. And that's typically what you'll see in, fractures of like the femur, where you have a lot of big muscles that attach on those distal fragments. So because you have all those muscles, when you have a fracture, the muscles will pull the fragments together like this. And that will cause shortening. And you'll actually see, if you've ever seen a patient with a femoral shaft fracture or a hip dislocation, their leg will literally just be shorter than the other. And oftentimes it'll be externally rotated depending on the direction of the dislocation or fracture. So that's something you can look for pretty quickly. Here we are talking about angulation. Again, this is the lateral side. So this is laterally angulated 30 degrees. I would say this is valgus angulation. Same thing, just, the terminology. So you have valgus angulation of about 30 degrees here of the distal fragment, right? The distal piece is aiming valgusly. Okay, here we have 45 degrees of valgus angulation. We have a little bit of lateral displacement. Yeah, that's about it. And here, we have a pretty gnarly fracture where we have 45 degrees of valgus angulation. We have actually medial displacement here, and we have shortening. Okay. And this is actually a pretty common pattern picture you'll see in femoral shaft fractures. Okay, any questions on this so far? Would they use distraction to help realign? Yeah, that's actually how you would realign it. We'll get to that. Okay, all right, moving on. So we have all the pieces of our fracture description, right? We have, our introduction where you say, okay, this is an AP, oblique, and lateral view of the, right or left insert body part in a skeletally immature versus immature individual with a fracture, and then you kind of go into your fracture description, and you have all these words and descriptors in your arsenal where you can talk about the pattern of the break, the location, where it is, why that's important, the deformity. And again, these all help you fix it. So that's why it's important to know. Other considerations, let's say you're the intern and you get a call from the trauma team or the ED, and they say, hey, we have this really deformed right lower leg. It's very obviously a fracture. You can see there's like a deformity. You got to ask them, is it open? Sometimes, you know, you'd think that they would tell you that, but oftentimes you have to ask to make sure, is it an open fracture? And the reason why that's so important is because there's really one thing that is proven to help with open fractures above all else, and that's early administration of antibiotics. So you have an open fracture, antitetanus. Don't even think about it. Like literally just, if you think it's an open fracture, just give them antitetanus. That'll go a long way. It can save you from a lot of infections. And you won't get in trouble as long as you remember to give antitetanus. Then, you know, you worry about, like we said, the location of the fracture. To get into more nitty gritty, the reason why that becomes important is because you worry about joint involvement. If it's extra-articular, typically it's a lot simpler to fix. If it's intra-articular, you see it start extending into the knee joint, extending into the ankle joint, extending into the carpus of the wrist. You start to have a little more of a complex situation there. And typically you'll need to get a CAT scan at that point to better evaluate the fracture and to map out your surgical planning a little bit better. Okay. And then, like we talked about earlier, you got to always think about, you know, nearby vessels that are important to consider, ones that would require immediate fixation, ones that would lead to instability down the road functionally, ones that might need repair, you know, maybe now, maybe outpatient, and certain nerves. You might get like a neuropraxia that might come back, or you might get a nerve that's completely transected that you never knew about, but you're all doing your physical exam. Great. So you're going to pick up on that. All right, so let's do a little practice here. So I'll kind of walk us through the first one, and then we can kind of open it up and people can just contribute, you know, openly, however you want to. But let's just remember how we're going to start with this, right? So this is your AP, oblique, and lateral view of your right wrist in a skeletally mature individual. And let's start talking about what we see in this fracture. So anyone can just chime in. We can just talk about it, have a little discussion.
There's radial shaft shortening with distal, or with dorsal displacement of the distal fragment.
Mm-hmm. Right. So which X-ray are you seeing that on?
On the lateral, you could see the dorsal displacement. You can see the shortening on the AP and the oblique. Radial inclination looks okay. Yeah.
So your parameters like radial inclination, radial height, those are things you can get into later. But for now, yeah, it looks like there's radial shortening here, and there's dorsal displacement. Right, so this is displaced dorsally. What about the angulation? Someone else want to give it a try? Who wants to talk about how it's angulated? Anybody? Be brave. It's okay. You can be wrong. I won't judge you.
Yeah, so when you're talking about angulation, I know we talked about dorsal versus ventral, but then you also gave degrees. So if you were asked this question, you know, would you give degrees as well as the direction?
You don't really have to. I mean, if like someone's really pressing you and like, oh, like how angulated is it? You know, you can give them degrees if you want to be fancy, but oftentimes you don't really have to say the degrees.
Okay, so you could also say, would you say like dorsal angulation also?
Yeah, good. Yeah. So why are you saying that? Oops.
Because it's like shifted towards the back of your hand, so like the dorsal side of your hand.
And which part is shifted to the back?
The distal.
Good.
The distal fragment.
Right, exactly. So the distal fragment is dorsally angulated. It's angulated to the dorsum of the wrist. And this is a part that kind of confuses people. Another way to describe this fracture is dorsal angulation or apex volar. Okay, that kind of confused me for a while because you'd say, oh, there's apex volar. I was like, oh, I thought it was dorsal angulation. Well, it is. They're both right. So your fracture pattern makes a little apex here. The apex is volar and the distal fragment is dorsal. So if you say like, how is this fracture angulated? You could say, oh, it's dorsally angulated or it's apex volar. Okay.
That makes sense.
Nice. Yeah. So why is that important? Why is it important to know the angulation? So let's say you're the intern and you go in and you see this patient and you see the x-ray and you say, okay, well, we got this dorsally angulated distal radius fracture. You know, it looks like there's a little bit of radial shortening, like PJ was saying. Looks like there's a little bit of dorsal displacement, dorsal angulation. What are you going to do about it? So you don't want to just go in there and start cranking on it, right? Because then your patient's going to hate you. And, you know, they're probably going to come in like very tender, like, ow, 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 like can't move it, you know. You're going to ask them to wiggle their fingers. They're going to be very ginger about it. You can't do anything like that. So what you do is it's called a hematoma block. Okay. So you ask the nurse for some lidocaine and you draw it up in a syringe and you put your needle straight into the fracture site, like right into the hematoma. That's why it's called a hematoma block. And that actually works really, really well. If you get it just right, they don't feel a thing. Their arm just starts flapping around in the wind and like you can manipulate it however you want and it works great. The patient's happy, you're happy because you can crank on it without them freaking out and making it harder for you. So how would you insert your needle? Anybody? Would you go dorsal or would you go volar?
I feel like if you go volar, I mean, I don't really know. If you go volar, I feel like you might hit more nerves, like the median nerve or.
Right, exactly.
Okay.
You got your carpal.
Yeah.
Yeah, you got your carpal tunnel right here. You have your median nerve, which is, you know, I think it's pretty important. You got a bunch of tendons going in here, right? So if you stick a needle in there, it's kind of hard to like know for sure that you're not going to injure something. Whereas what's on the dorsal side? You have some extensor tendons, but you don't have a super important nerve back there, right? So when you're doing your hematoma block on a distal radius fracture, you always go dorsal, okay? So now we know which side we're coming in from with the needle. How are we gonna go in? Are we gonna go in an angle? Or are we gonna go in perpendicularly? So we wanna get it directly into the hematoma. So we're gonna feel with our fingers, we're gonna palpate, you know, this fragment of bone that's kind of sticking off. You can feel it, you can see it, but in orthopedics, you use a lot of feel. It's all about feel. When you're drilling through a cortex, you got to feel that drill go through the cortex. When you're feeling this fracture segment, you want to feel that fracture line. Okay, so when you feel it out, you kind of mark where you feel like that step off is happening, and you kind of just take the needle and you just go straight into the fracture site. And then once you think you're in, you'll draw back a little bit and you'll see a flash of blood if you're in the hematoma. And then once you're in there, then you just inject. And they're going to be like, ow, 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 because there's a lot of pressure in there. But 5 seconds later, they're going to love you because all of a sudden their pain is gone and you can do your job and they're in a lot less pain. So you do your hematoma block based on the angulation of this fragment, right? And you can all feel it on yourselves. On the dorsal side, you have what's called Lister's tubercle. It's you can feel it. So you can feel your ulnar styloid. You can feel your radial styloid, right? And then on the radius, if you kind of just like palpate along the dorsum of it, you can feel this little tiny like protrusion of bone. That's called Lister's tubercle. That's a little area where there aren't any tendons going over it. So it's kind of your safe zone. right? So when you see this fracture, you're feeling for the step off, you're feeling for your fracture site, you're feeling for that Lister's tubercle, you're kind of aiming there and you're aiming straight into the fracture site, drawing back blood and injecting, and you're good to go, right? Then you're ready for your reduction, okay? So how would you reduce this? Well, it's pretty simple, actually. You just put your thumbs on that step off on the dorsum, and you just push it back into place, essentially. And if that doesn't work, that's for easier fractures. But the more proper way to do it is you can grab the thumb, okay, and you want to recreate the deformity. So you'll kind of bend it back. So with my left hand, I would have my thumb on that fracture site, like right, my thumb would be right up on here. And with my other hand, I'd be grabbing the thumb. And with my leg, it's kind of funny, I'll actually put the leg over the arm like that. So I'll put my leg over the person's arm, their arm will be straight up like this. I'll have the thumb in one hand, I'll have the fracture site on the thumb on my other hand, and I'll pull traction with my leg and on the thumb, and I'll push it over into place. That's how we do it here. Hopefully you get your reduction, and then you can splint it after that, right? So you don't want to just let the reduction fall back and lose all that hard work you just did with your hematoma block and with your reduction. So you got to keep it there. So now you do your sugar tongue splint. And in orthopedics, we don't like straight splints. We put a splint on for a reason. You want to hold that reduction. So what you'll do is you'll mold the splint such that, right, like if I have a dorsally angulated fracture, you'll mold the splint kind of like that, so that it stays in place and can't fall back, right? So you see how understanding the pattern of the fracture, the deformity of the fracture, the structures nearby, all that ties into how you're going to treat it. Cool. Any questions? Any thoughts? All right, cool. Let's move on. All right, so you guys are gonna do this one on your own. Talk me through it as a team. What do you see? Let's have some new people. Oh, sorry, PJ.
No, that's okay. I was just gonna say three views of left wrist.
Mm-hmm. Okay, good place to start. Who wants to pick up from there? Which views are you looking at?
AP, oblique, and lateral.
Good. Okay. So you have your AP, oblique, and lateral view of the left wrist. Right. So let's describe this fracture.
Well, it looks
incomplete. Oh.
Sorry. No, go for it.
Go ahead.
I was just gonna say it looks like there's a medial and a volar displacement.
Okay, so why are you saying what you're saying?
Because medially it's like the hand, like, or I guess like the metacarpal bones look like they're, and the distal portion of the bone looks like it's displaced towards the thumb, which is medial, and then
which views are you seeing that on?
Oh, the AP, and I guess in the oblique also.
Mm-hmm.
And then in the lateral view, you can see that it's displaced towards the palm of the hand.
Mm-hmm. So it's not really displaced that much. If anything, which way is it displaced?
Towards the palm of the hand?
Mm-hmm. So what would that be? Would that be dorsal or volar? Mm-hmm. Yeah, you could say there's a little bit of volar displacement there. All right, that's hard to see. That's why you need all three of your views, because if you're just looking at the AP, let's say you're just looking at the AP and you're seeing you know, there's this medial displacement. You could say that there's some shortening, but you don't know if this is on this chunk is on the dorsal side or the volar side. It's hard to tell, right? With the oblique view, you still can't even tell. That's why you look at them all together, and the lateral will tell you, oh, okay, now I have the whole picture. This is going that way. This is going this way, you know? So cool. So let's talk about the angulation. Come on, anybody, don't be shy. Somebody new. We can sit here all night. You guys can go out and drink beers, or you can sit here with me listening to a PowerPoint. Just give it a try.
I mean, I think it's like definitely volar displaced slightly. Angulate, I mean, I don't really see much angulation. Like, what angulation are you getting at?
Like volar versus dorsal angulation.
I mean, I'm gonna go with volar angulation.
Okay, why are you saying that?
Well, I mean, I'm trying to like determine the volar like tilt on the radial head, but I can't really like, I don't, is that like you can't even see my cursor. Is that like the distal head of the radial shaft? Is that like a fragment volarly displaced?
Yeah, so this whole piece, right, that I'm outlining, that's like the distal radius that usually sits like straight right here.
Okay, got it.
Yeah, so it's kind of hard to see. If you don't know what like a normal distal radius looks like, it's much harder. So you know, it's good to study like what normal looks like. That's why I have my friend over here in my corner of my room. Like I literally just stare at it sometimes just so I know what normal looks like. Not because I'm a creep and keep skeletons in my closet, literally. So yeah, I like to look at normal anatomy so that you can see when it's off. So this whole piece right here is tilted volarly, right? It's tilted towards the palm, right? Let's go back to the other one, right? You can see how this whole piece would be sitting on top right here, right? Whereas in this one, this whole piece should be sitting on top right here. Okay, so this is actually volarly angulated, or that's another way to say that. Apex.
Dorsal.
Dorsal. Yeah, and you see that, right? Like the apex of the fracture is like, right? It's the apex is pointing dorsally, and the distal fragment is pointing volarly. Okay, so this is a volarly angulated distal radius fracture, or apex dorsal. So how would you do your, okay, so what do you do next? Now that you've assessed your x-ray, you know what the fracture looks like, what do you want to do?
I think you were talking about before, like the hematoma block. So
yeah,
injecting lidocaine, it'd probably be much easier to do it dorsally now. You can feel the break. And because it's apex, or not apex still, sir, it's on the volar side, the displacement, you can be able to just put the needle straight in instead of on an angle.
Yep, exactly. So you can actually take your needle, right? So remember in the last one, we were going, we were going dorsally and we were aiming it this way, kind of the needle pointing towards the hand. Whereas now you're pointing the needle more towards the elbow, right? And now you're getting a clear shot straight into that fracture site. You're gonna stick the needle in there, draw back a little blood, and inject into the hematoma site. Now your arm is free to manipulate, and you're essentially gonna do the same thing you did last time, but the opposite way. You're gonna put your thumb right onto this fracture site. You're gonna put your leg over the humerus. You're gonna grab onto the thumb recreate the deformity going volar first, pulling traction, and then using your thumb to get it over. And then when you make your splint, you're going to mold it so it doesn't fall this way. You're going to mold it a little more that way. Cool?
Jason, I have a quick question.
Yeah.
How do you decide what needs reduction versus surgery?
Okay, so there are very specific parameters that, you know, that's kind of what you're expected to know when you're like a fourth year medical student. That's kind of the stuff they'll ask you. But there are very specific like numbers, right? So when you get into more detail, you worry about like the radial inclination or the radial height or the volar tilt. Like there are specific numbers you look for that you can measure. And if those things are off by more than a given margin that's described by like the community, then most people would operate in those situations. And then there's a lot of gray zone. It's not quite as simple as like, oh, you know, there's this. Every fracture pattern is different, which is kind of cool. Like it's not like every distal radius is the same. They're all their own little snowflake, right? Like if you have a little piece of intra-articular extension here where you're going into the joint, you know, some people might operate on that. Some people wouldn't. I think most people would. If you have, you know, a little bit of widening of this joint because you're articulating with the carpus here, that's your wrist bones. So if that doesn't heal right, you're going to lose a lot of wrist mobility. That's a big problem, right? So there's a lot of factors involved, but good question. That's like the next level after you're kind of situated with like, you know, like the basics. That's like fourth year med student, like that's like stuff you should start to know then.
Got it. Thank you.
Mm-hmm. And all this information, if you're ever curious, Ortho Bullets is a great website to learn these things. Like literally, it's like it has everything. I mean, it's kind of a bridge. It's kind of like a first aid for ortho, but better. It's literally in bullet format. Tells you all the things you need to know, and they'll always tell you the classification. They'll tell you the parameters for surgical indications and not. So if you're ever curious, you can just take a look at those. And I wouldn't spend a lot of time memorizing those now, but when you're starting your fourth year, I would definitely study that. Cool. Sweet. Next.
Hey, Jason, I think we're going to go like one more and then maybe just take a couple questions and then we might end it in a little bit. Usually we do it for about an hour. That's okay.
Okay, sure.
Yeah, we'll go like another like 5-10 minutes just because I know the M1s have an exam on Friday.
Oh, they do?
So yeah,
oh,
yeah.
Damn, I didn't know that. I'm sorry, guys.
No, that's good. We started like 10 minutes late, so we'll do this one and take some questions too, if you don't mind.
Yeah, sure, that's fine. So what are you guys seeing here?
Looks like it's a left arm, both bone forearm fracture.
Okay, good. So what views are we looking at? Same, we got our AP, we got our oblique, and we got our lateral. And just like you said, we have a left both bone forearm fracture, which is pretty common in a specific group of people.
Is one of them a green stick fracture or is it complete fully?
I would call them both complete. You can see the cortex is not continuous here and here, you know, over here, you can see that. It's like overlapping because of like how it is in space, but it is disrupted. Good thought though.
In the oblique view, is the ulna displaced or is it just like, because it looks a little bit overlapped to me?
Mm-hmm. Yeah, that's a great point. So look at the AP view, right? It's not like super displaced in the AP, but when you look in the oblique, it looks displaced, right? So that actually does happen when you look at an oblique view. It will look a little more displaced than it actually is. So that's definitely something you want to look out for. Yeah, like that's why an oblique view on its own sometimes can get you into trouble because it's not quite right. Like imagine if it's perfectly aligned and now you look at it from this side, it's gonna warp it a little bit. So that's a good catch. And that's why you got to look at them all together, right? One view in and of itself isn't sufficient. Good. Anything else you guys see?
I kind of look both dorsally displaced. I'm not sure if there's
Okay.
angulation.
Yep. Dorsal angulation, because the distal fragment is pointing dorsally. What's another way to describe that angulation?
That's the apex volar.
Good. Yep. Exactly.
There's a child too, because we can see the growth plates.
Yep, exactly. Yeah. See right here, growth plates right here. So when I was an earlier med student, I used to think that those are fractures. I used to be like, wait, are those fractures? Are these fractures? Are these fractures? Like what happened to this person? Like what on earth were they doing that they just fractured everything exactly where the epiphysis is on every single bone of their hand? Oh wait, they're growth plates. It's a child. Bam, drop the mic. Yeah, so that's why it's important to go through your formula. You say there's an AP, oblique, and lateral view of a left wrist in a skeletally immature individual showing a left both bone forearm fracture that appears to be transverse and dorsally angulated. Now, whoever you're talking to knows exactly, they can visualize this fracture and what it looks like without having to see the x-ray essentially. You know, and then you can say this is a distal both bone forearm fracture. So they know it's not mid shaft. So they know it's not proximal, right? And the way you'd fix this is, you know, you could do a hematoma block. You could, with kids, we often sedate them with conscious sedation. So they're out cold. So it's a little easier on yourself. And with this one, you honestly just put your thumbs right here on the apex. That's why they use the apex volar. You put your thumbs on the apex and you just push it in and you crunch it in. You'll feel a crunch. And then boom. There's your reduced both bone forearm fracture. Not to toot my own horn, but this was my first reduction ever. I think it's pretty sweet. And if you say otherwise, I will remember your name. Okay.
Great job,
here,
looks great.
Thanks, man. Thanks. I needed that. And here you have your sugar tongue splint, keeping it in shape. Cool. So we'll just quickly go through these next slides. We're not going to do them all together, but this is a fracture that actually came in the other day, like while I was on my trauma rotation. Pretty gnarly femur fracture. You have your deforming forces. You have shortening here, right? Like we were talking about. We have medial displacement. We have anterior angulation, right? Posterior like displacement here. Like it's just bad situation, right? So this is what we talk about. It's called traction. This is how you reduce this. Is you take a pin, you drill it through either the proximal tibia or their distal femur, all right? And you literally do this while they're wide awake. Like usually they hate you while you do this. You'll take lidocaine, you'll numb up, you know, the periosteum, and you'll just drill it through. And then you'll attach it to a traction bow, put it on this part of the bed and lay weights on it, and it'll pull their femur out to length. And this is how it was before. And again, this was my first traction pin. It's a little more anterior than I'd like it to be, but it did its job. And that's the fracture after you put the weights on. And this is what you do overnight until they go to the OR, so they're not writhing in pain for 24 hours. Cool. And then this is the surgery that they do to fix it definitively. They put the intramedullary nail in. You have right through the fracture site and distal interlocking screws. And this dude can walk home the next day. Okay, so the last thing I want to leave you with is, this is kind of going to lead into our next lecture, but you know, why it is we do what we do. Like, you know, you don't just splint it just because people told you to splint it. You don't reduce it just because people told you to reduce it. These are like the 4 AO principles of how to heal a fracture. You want to get good reduction. You want to get good length. You want to restore length, alignment, and rotation. And you do that with, you know, the reduction techniques. you hold it with a splint or with a cast or with traction, and then you stabilize it, like we talked about earlier. I'll go into this in more detail next time, absolute versus relative stability. That's where your surgery comes in to stabilize it. You can use a plate, intramedullary nail, a rod, whatever. And then you have to make sure you have good soft tissue coverage. This is where our friends in plastics and vascular will come help and get involved. If you have a poor blood supply, you're not gonna have a good fracture union, right? We were talking about earlier with the femoral head, avascular necrosis, non-union. All those things happen if you don't have a good blood supply. And lastly, mobilization, right? Because at the end goal, it's function that we want to restore, right? Like if you can restore radiographically all these parameters, but if they're not using their limbs the way they want to, if they're not living their life the way they want to, that's not great. So you want to restore functionality. You can get really stiff if you do rehab and start getting them walking and moving quickly. You can get DVTs and get pulmonary embolisms. I've seen that, so these are all why we do what we do. And pretty much everything in orthopedics is trying to optimize these 4 things. Cool. So thank you guys for listening. I hope it was helpful and interesting. Not too much, not too little. And yeah, what do you guys? Yeah, if you guys have any other questions about life or orthopedics or residency or whatever, hit me up. I don't bite. I am very busy, but I will try to respond to everybody. Yeah.
Hey, Jason, this is Dr. Cott. I don't know if you can hear me there. And, first of all, I want to say that talk was just fantastic. I mean, that was not an intern level talk at all. And that was, it took a lot of time for you to put that together and you delivered it really well. So I thought it was fantastic. And I thought it was just absolutely appropriate for the students on the call tonight. And for the students here, I mean, if this is your first introduction to the Department of Orthopedic Surgery, I want to welcome you and, introduce you to your leaders, your orthopedic interest group leaders, PJ, Peter, Christina, and Steve. They've done an excellent job over the last 4 months putting together a nice curriculum to introduce you to orthopedics, find ways for you guys to get involved, both with the education and the research. And we have a lot of great stuff to offer over the year. So hopefully you'll keep coming back and taking a look at what we do, because it's pretty cool stuff like Jason showed. I mean, we take people when they're, at their worst, and we have all the technology to try to make them better. And it's pretty amazing stuff. So welcome. And then, Jason, I mean, maybe you could talk for a couple minutes, and PJ, if we have time, that you could just talk about like your journey to get where you are. And, you're obviously one of the top students that Robert Wood had, and we're lucky to have you. But maybe you can just mention kind of what it took to get where you are, and maybe give them a little bit direction of where to go.
Yeah, absolutely. Thanks, Dr. Kai. I wasn't sure if you were listening, but yeah, thank you. Yeah, it's a tough road. People don't necessarily know that this is what they want to do early on. I kind of had the lucky experience of having early exposure and kind of knowing it was on my differential as an M1 and M2. I kept an open mind throughout all of med school. I treated every rotation as if, this is what I'm going to do for the rest of my life. How would I enjoy it? Whether it was family medicine, OB-GYN, neurology, I really imagined hey, if I did this every day for the rest of my life, would I be happy? And so I never really committed until really my first ortho rotation at Robert Wood formally was supposed to be at the end of my 3rd year. It didn't happen because of COVID. So I actually ended up taking step 2 during that time, and I didn't have my first real ortho rotation until 4th year. And admittedly, I was a little scared because I was like, what if I go into it and I don't love it? And, now I'm a 4th year medical student. I'm supposed to be applying soon. I don't know what I want to do yet. But within my first week, luckily I just fell in love with it and was like, yeah, no question, this is what I want to do for sure. I love the people. I loved the culture. I love the thought. I love the application of physics and the technology, and especially the outcomes. Those were the biggest things for me. And, you know, you kind of just, even if you don't know for sure it's what you want to do, it definitely helps to kind of, the ortho is one of those competitive specialties where you always have to be kind of doing something with it. Otherwise you'll fall behind, unfortunately. So even if you're not committed to it, I would try and get involved in some research. Even if it's just a little bit, just get your feet wet. It'll help you, one, get ahead if you decide to do orthopedics, and two, you know, any research experience is worthwhile no matter what field you go into. You know, when I was on my general surgery rotation, we had 2 weeks of an elective. All my friends were like, oh, you're gonna do ortho, right? And I was like, well, yeah, I don't know. I'm gonna do a lot of ortho later on. I kind of want to see what else is out there. So I legitimately didn't even choose an elective, and I just let like the administrators just randomly put me in one. I ended up in a 2-week plastics elective and absolutely loved it, learned a lot. And what I learned in those 2 weeks actually serves me really well in ortho when people are talking about like flaps and grafts and all those things. And some of the orthopedic surgeons don't know, you know, the nitty gritty behind that, but I learned it, and you don't realize how helpful it can be down the road. So I would say have an open mind, but also like, you know, try and do little bits as you can along the way, and talk to people, like talk to your friends, talk to, you know, mentors, talk to attendings if you can. Dr. Cott is very available. I'm going to try to make myself as available as I can as I survive intern year. So, you know, hopefully we'll do more of these lectures, and you guys can reach out to me however you want. So yeah, that's what I have to say about it. Anything else, Dr. Cott, or anybody?
No, I thought that was great. Maybe if you want to take a few, you know, specific questions, that would be awesome.
Sure. Yeah. If anybody has any, don't feel pressured to ask a question if you don't have one, but don't be shy.
Hey, Jason. Sorry.
Go ahead,
I have a quick question in regards to when you're relocating a patient's fractured arm but using your leg. What position is that patient in?
Yeah, so if it's like a distal radius, that's a great question. So much of surgery and just any sort of procedure is about positioning. If you don't position them well, you're gonna have a bad time. Like I've like thrown out my back just from like forgetting to position patients optimally. So in the example of a distal radius, you have them completely supine, and you'll have your arm out like 90 degrees with your elbow at 90 degrees and your fingers pointing straight up to the ceiling. And you'll put your leg over like the humerus so that your thigh is like pushing down on the humerus. And then you'll have your hand pulling straight up traction on the thumb, because you're kind of trying to restore radial inclination, which is what we talked about earlier. There's like a little bit of don't worry about it. But basically you want to get that traction and then have your thumb kind of pushing it up and over, if that made any sense. If I were in person, I would do it to you so that you understand. But unfortunately, we're on Zoom and your radius is fine.
No, yeah, that's great. Thank you.
Mm-hmm.
Jason, do you have any recommendations on like when to start research? I know PJ mentioned, I remember him mentioning like it's important to understand anatomy maybe even before you start research. Do you have any tips on that?
Yeah, honestly, I would say it's like never too early. You know, if you're an M1 or M2, like people won't have like terribly high expectations of you, not because you're stupid, but just because like you're an M1 or M2. Like, so just getting involved and like just seeing what's out there. Even if it's something like, I remember like my M1 year, I was just chart checking for like an entire summer, and it sucked, but I was like slowly, like, but surely like picking up on like, oh, like this is what like a distal femoral replacement looks like. Huh, interesting. Like, oh, like what is that? Like just like looking at these x-rays and like having no idea what I was looking at, but just being exposed to it, I think helped a lot. So I would say there's no such thing as too early. Yeah, if you have the opportunity, I would jump in.
Thank you.
Mm-hmm.
Sorry, just real quick, related to that, I think I also remember that there was talk of like a database of kind of ongoing projects in ortho that we could access and use to reach out to people who would potentially be interested in taking us on. I don't know if you know where that is or how we would get access to it.
Interestingly enough, the man who's kind of the spearhead of that is on this Zoom with us. Dr. Cott has a very wide army of people who are trying to do research with him, and he's got a bunch of projects going on, and he's always making progress on them. So, you can reach out to me or any of the residents or Dr. Cott. I don't want to blow up your email, but I think he would be more than willing to have more people come on and help us out.
Cool. That sounds great. Thank you so much.
Yeah.
At some point, we will send out a Google form with, if you're interested in research, just so we don't blow up everyone's emails and we can hopefully funnel you into projects. So be on the lookout for that.
Great. Thank you.
Yeah. Yeah. We have like a schedule too. Like we're definitely going to get people who are interested on stuff. We're just making sure that we have things available for everybody. We don't want people to like just get stuck with nothing, We want it to be meaningful for you.
Yeah, that makes sense. Thanks.
Any other questions about anything?
If not, one, thanks a lot, Jason. We appreciate the time. This was great. I hope we continue to do this. I think people really liked it. We got a lot of positive feedback already. And then just some announcements. We have our first journal club coming up. Is it next week, Christina?
It is on the 30th. So I'll send out that email. Look out for that either tomorrow or Friday morning.
Yeah, and then we're going to be having a talk. I'm going to be reaching out to Dr. Gatt, who is the chair of the residency program at Robert Wood. He's going to be giving his annual talk on like getting into orthopedics, how to be competitive for it. We're going to try to do that in September. And then once he gives that talk, we'll try and really get people involved in opportunities in a department. Hopefully we do some more stuff in person, but with COVID, we'll see. So we'll keep you updated. But thanks everybody for coming. Jason, thank you so much. And yeah, let's have a good night, everybody. Good luck M1s on your test on Friday.
Good luck on, what is it, EBM? Oh,
yeah, the curriculum's new now. It's like, it's totally new. It's not the same anymore.
Well, whatever it is, good luck. Go have fun afterwards. Enjoy it while you can. All right, thanks for coming, everybody.
Thank you so much. Bye.
Bye.